It's going to
That's
say
right.
we're recording.
That's great.
And okay, and for now, take it away. You're on.
All right. Thank you. So, today, what we're going to talk about obviously is going to be human cell and tissue product intervention as it relates to taking care of patients, the everyday patient, right? And so, before we get started, I want to talk about how to pair nutrition and lifestyle intervention in a human cell and tissue product, centralized intervention. And so, we're going to talk about that today. This is something that we have been able to generate with biogenetics. Um, I mean, for the last couple of years, we've been just serving practices that specialize in this. And so I'm excited to be able to talk with you guys about this today. So I'm Dr. Brad Watts with Biogenetics, by the way. And I am a chiropractor. I'm a specialist in functional medicine or clinical nutrition, and it's the only thing I've done for 12 years. And we've seen thousands of cases in consultancy and otherwise. And so excited to be here. So thank you, Dr. Clearfield, obviously, for giving a platform for this. That's great. So, all right. So we're going to get through some of this here, some FDA information regarding supplementation as per usual. And nothing out of the ordinary there, but um, got to give the FDA their 2 seconds there. So here we have something that I hope in an integrated clinical setting is not anything new for anybody that's listening to today's broadcast. And essentially, lifestyle and genetics is what's causing the United States to get flushed down the toilet right now from a healthcare perspective. But I also want everybody to understand that lifestyle and genetics, the same thing that got us into the pickle, is what gets us out of the pickle. It's interesting that most healthcare providers understand lifestyle and genetics are what put us into a position, whether it be arthritic issues or whether it be obesity or diabetes or anything like that. And it's interesting to me that that's not also first line of thinking when it comes to resolution. So I'm out to change that. So my mission in life is is to make sure that people get this image burned into their retinas, and it's this: you have control over the expression of your genetics, and it's pretty exciting. So when you can show patients this in real time, um, apathy tends to walk away real quick, and so I appreciate that. So anyway, so see where we are in this today. This is what we're going to be talking about: is how, from joint destruction situation, human cell and tissue product and nutrition compare together to point this patient from the red side, right, back to the right side of your screen, moving these patients toward wellness. So obviously that's going to be, our strategy here. The problem is that when we talk about nutrition and putting it into practice, just in a general medical clinic specifically, and I don't really want you to be too hard on yourselves, right? But in any practice that doesn't start from the ground up, specializing in nutrition, what happens is people try to reinvent the wheel, so to speak, and make it more complicated than it needs to be. And so we end up with, a shift pattern that looks like this. So people trying to integrate their practice, and it's crazy. And there's no systems, or the systems are 19 layers deep like this one, or 20 layers deep, and the patients can't participate because nobody knows how it works. And so anyway, what we're doing at Biogenetics is we're simplifying this, and we have a plug and play lineup of nutrition products that specifically are targeting patients that are dealing with, number one, degenerative arthritic conditions; number two, neuropathic neurogenic pain issues; inflammatory weight loss, whether that be the results of that being obesity, diabetes, etc., and then also cognitive decline. So the plug and play nutrition programming that we offer is certainly going to be regen support, which we're going to talk about tonight. Not really about the regen support kit, but about the mechanics of it, how it works, and a metabolic clearing program. So if you want more information on those things, obviously we have a lot of education surrounding that and how to plug and play with your patients. So what I want to do is I want to start out with a couple of these things that the younger generation, younger than me even, are participating in on a daily basis. And these are memes, and I have a couple of them that I want to show you because Really, we're going to talk about two types of patients tonight, and I want you to get the idea behind this before we go. So the meme always starts out like this. There's two types of people in this world, right? You have the person on the left who has single word text messages to tell you something. And you have the person in the right who's an analytical thinker, and they can put their thought process into words and put it in a paragraph, finish a thought before they send it to somebody. And here you have what you're looking at. I can laugh and say that I'll be on the right, and my wife is definitely the person on the left here. Okay. So I want you to see this. All right. There's two kinds of people. Here's another one for you. We have the person that can wake up at 7 a.m. with one alarm. Then you got the person with the 5 alarm scenario. And the two kinds of people continue to demonstrate who they are and what they're up to. Here we have the email situation. Once again, I will say that the one on the right-hand side is more along the lines of my wife. She's a clinician as well, so I can pick on her a little bit. But we get this, okay? So I want you to see if you can identify yourself in any of these things, because when we look at the two types of people, we still have to figure out the people that you work with as well. Okay, and here we are looking at that. You have two types of case managers in an integrated clinic. You got one person on the left-hand side that walks into the room with the patient and they say, what do you want? Right. And then you have the person on the right here who's just excited because it's Tuesday and it's the best Tuesday ever, right? And so somewhere in the middle of that is probably somebody you want to work with. Okay, now, if we can pick, right, how you participate with text messages and emails, if you can pick the people that you get to work with, then you also got to think about the people that you're admitting into care in your practice, especially from an integrated or from a regen-centric perspective, which is really what we're going to focus on today. And so what's interesting to me is that the same way that we have case managers in an integrated clinic, we also have two types of patients. And so the two types of patients that show up specifically are the guy on the left, right, which is the everyman, right, and then the guy on the right, which is a 70-year-old marathon runner. And when people are in an integrated practice, like what they're dreaming about, what they're dreaming for is the marathon runner, right? His life is basically in order. He shows up, he's got knee pain. Why? Because he's been putting in the miles, right? And he's got an isolated issue. Okay, his knee pain has a mechanism that everybody can understand. And you look at it and you say, hey, that makes sense. Okay, that makes sense. But the reality is that for every guy that you have like this, that's a 70-year-old marathon runner, you have 100 patients that are like the gentleman on the left-hand side who might be an accountant or a lawyer, right? Or a bus driver or whatever. And this gentleman sits for a living. And this gentleman enjoys nutrient-dense foods. This gentleman, might be on 3 or 4 different medications at this point. He's getting ready to go into retirement. It looks like here, maybe he's, 60, 65 years old. And he's trying to figure out, what does his retirement look like? And you all know what his retirement looks like. It looks like him managing chronic disease. And so as we go through the process here today, modern medicine has done some pretty amazing things with human cell and tissue products that I'm going to talk about. But what I want you to see is that the fate of those interventions is really this gentleman's lifestyle, right? It's really what he puts in his body. And it's a pretty interesting scenario that bears itself out in the medical literature. And so we're going to look at a couple of pieces of that today, all right? So I want you to keep this guy in mind, okay? Because ultimately, this is the person that we're going to have to serve. And, somebody's got to save this guy too, all right? So for all of those of you that are heavy in maybe in the regen area or focusing on the integrated side as it relates to nutrition for joint health, etc., I want to make sure that you are seeing your patient clearly, because companies that are producing human cell and tissue product interventions and materials, marketing materials, they never show you this guy. They always show you the marathon runner, and you get excited to get in and work on some specimens. Okay. And sometimes that's not the case, right? For the majority of us, that's not the case. So there's two types of patients I want to talk about. So there's a question that I often get as we look at human cell and tissue product intervention in food. And it's this: how does food-based inflammation turn into targeted joint destruction? And really, the autoimmune researchers, they're the ones that understand this better than anybody, because they're the ones that study those pathways. And so what I want to do is just highlight a couple of points here, and we're really going to dig in on the functional aspect of this. Okay. So coming from any of these titles, you can just punch them into Google and you can find those, by the way. Okay. But when we look at autoimmunity and we ask, how does food-based inflammation, like how does somebody eating food that their physiology is not compatible with, how does that go from my gut is swollen to targeted joint destruction? And ultimately that happens through the recruiting or the development of autoimmune responses. Now, our testing is pretty interesting when it comes to autoimmunity, but in a subclinical realm, okay, life exists in a continuum. Right? Before anybody ever has antibodies to a tissue, they have to have had that instructions manifested, right? So the DNA expressing itself, and we start to see tissue, starting to come under attack. And even before we have, clinical levels of antibodies, well, Th1 activity recruits Th17 activity, and that happens when the repeated stressor, the inflammatory mechanism, doesn't go away. So we have this innate intelligence, right? You have Th1 activity, this innate immune system situation where if you sprain your ankle, your ankle swells up. Like playing basketball, if I sprain my ankle, my head doesn't swell up, right? Just localized. But when that localized reaction is in the gut or ends up with, NF kappa beta activity that hits the bloodstream, and we're going systemic, all over, what happens is that if that Th1 activity doesn't slow down, Th17 activity is certainly recruited, kind of like the military, right? You go from general infantry to, you want to go to the next level of that, all of a sudden you want to be a ranger, right? Or a Green Beret soldier or something like that. And what happens is this specificity starts to show up, and the more specific the immune system becomes, the more we allow it to specialize, the more targeted the destruction becomes. And it's an interesting process to watch itself bear out in your patient base, because you're not seeing a lot of autoimmune joint destruction in 10-year-olds, right? You see some of it, but not as much as you see in a population that's 70 or 80 after they've given the epigenetic switches a workout for 60 years. So just looking at this, I want to understand that Th1 activity will ultimately recruit Th17 if the stressor doesn't leave. And that's where integrated practitioners have an opportunity to step in and really improve people's quality of life. Okay. So what we look at here, just wanted to note a couple of different citations here, but when we have Th17 cells, right, enhancing and differentiation of osteoclasts via joint specific mesenchymal cells, this is the mechanism, right? This is the doorway to chronic joint destruction, not even in an autoimmune setting itself. This is the doorway to autoimmune joint destruction. And what's so interesting about this is that it doesn't take a lot for you to recruit Th17 activity. All it takes is chronic exposure, to an antigen, or chronic exposure to maybe a food stuff that your body's not a fan of. Okay? And people are not sensitive to the things in their lifestyle that are driving these reactions. But if you can take somebody that's sensitive or allergic, not even an IgE allergy, if it's even IgG or IgA, somebody that takes a sensitivity to something like corn, right? I live in the Midwest, and so you get 14 different types of corn growing all over, just all around you. And it's super interesting, the different responses that people get depending on where they get their products, right? But if you take somebody that's sensitive to corn product and they're eating chips just constantly because that's their snack, and they can't figure out why they start having all of these, doctor, I got the gout, or whatever it is, right? and they get diagnosed with inflammatory conditions where they're put on medication specifically to downregulate that, when really what we need them to start thinking about is how to stop pouring gas on this pathway. And it's really interesting. So I work a lot with, a variety of testing, as most integrated clinicians do. And it's an interesting way to assess your patient base. But what happens when they're that lawyer, that accountant that we looked at, and they've already been doing this for 45 years, and that Th17 activity is like, that ship has sailed. It's not turning off, relatively easily anyway, and the destruction has already been taking place, right? We look at that mechanism and what's actually causing it. So we have these two different layers of inflammation that I want to look at, right? The first layer of inflammation is that immune mediated one, where you start to see the presentation of foodstuff or mold, or maybe as a tick bite or something like that. You start to see a presentation where the immune system adapts in relation to that. But then we have this other one where it's like hand and mouth disease, right? So this other one where you eat food and you breathe oxygen and you mash two together and you make ATP, which you're seeing here, ATP supply in these little green balls that you see coming out of the mitochondria here. We also get this free radical damage, right? Now, I have a little 2-year-old at home here. If you hear anything, by the way, it's probably him. His mitochondria look like this, right? His mitochondria look like his skin. Okay, the phosphatidylcholine that makes up these membranes is like plump. It hasn't been damaged. Over time, though, what happens is you start to see people participating in this mechanism where the mitochondria become dilapidated, like a ship with holes getting blown in the side of it. And really, when we look at the lack of antioxidant therapy, frontline therapy as people are aging, this is what you're seeing: mitochondria breaking down, ATP supply shrinks. We have a truckload of reactive oxygen species being produced, and that inflammation, okay, if I can say something controversial, if that inflammation is not at least 50% of chronic disease, okay, then I would be very shocked, just in what we've seen over the last 12 years. Okay, I'll be very shocked. So what we see is that there's room for either the inflammation associated with metabolism in your body, or there's room for the inflammation associated with your lifestyle. Okay, you got these two different paradigms that I want to introduce you to. And when we look at these things, they both have a similar result, which is tissue destruction. Tissue destruction. All right. Are you guys still with me? I just want to make sure you get a thumbs up, or yeah, you can hear me, Dr. Clearfield, if you're there.
We're all here.
Okay, just wanted to make sure. So, all right, let's click on here. Here we have my graphic representation of our immune system that we just talked about, with the recruiting of the Th1 and Th17 activity. And traditionally, medicine, looks at this and they're like, the immune system is so complex, we can't organize it. And immunologists are, sitting in their labs by themselves for 2 decades, and they come up with this idea to explain it to the rest of us, where they're like, hey, it's like Th1, Th2 teeter-totter, and life happens in that balance there, okay? And it turns out that it's not as simple as they made it for us, right? But we have these naive lymphocytes at the top of the page here, the CD4, and you see this thick yellow arrow over to the Th1 activity. And that's because this on-ramp into immune system based inflammation is generally targeting this pathway, right? We go from a naive cell structure into a Th1 response relatively easily. Like, you could trigger that with just repetitive stress. Okay, but over time, you see this Th1 activity recruiting Th17, and we get this cycling back to Th1. There are a lot of people that get stuck in this mechanism, and we would look at them as Th1 dominant when we're talking about autoimmune diseases or otherwise. But it's not really that they only have Th1 activity. It's that Th1 activity keeps feeding back into itself through this Th17 loop, and we don't get the massive differentiation into Th2 antibody responses, or the classic allergy situation with Th9. Okay, so when people are stuck on this left hand side, they can go a lifetime with destructive inflammation, and nobody ever finds it because everybody's looking for rheumatoid, but nobody's finding rheumatoid, even though they have all of the symptoms. And these patients are left to sit there and suck on, their medication, okay, and like just sit there and bear it. And ultimately, it doesn't need to be that way if we can look at them from a clinical perspective. Let's put it this way, look at them from a diagnostic perspective rather than a therapeutic perspective. So most clinicians that I know are great at therapeutics, but not a lot of them know where they are in the biochemistry map. Like they can't look and say, you are here. And if you're here, then we got to figure out how to get to our destination. Most people don't have that in their brain, right? But that's changing because integrated practitioners like you guys are starting to bring some common sense into the everyday practice. And if we look at integrated health as anything, I hope we look at it as the common sense model, right? So looking at this Th1 to Th17 mechanism is where we can make or break a lot of these joint destruction issues in the long run. Now, I'm going to show you some of this in the medical literature in a minute, but what you're going to find is that as Th1 activity begins to grow, the reason it's growing after the antigen presentation, or after, even if a patient changes their diet, right? The reason that Th1 activity continues and remains is because of that mitochondrial mechanism that I showed you. Reactive oxygen species just wreaking havoc, okay? So this Th1 activity, we get, we basically get a double dose of it. And so I want you to see that before we get into this. So here's a graphic of how I explain care to patients and how I explain care to clinicians that we're teaching. And essentially it's a root and fruit graphic. So if you can see a tree in this, just use your imagination a little bit. You see the tree trunk here and the branches, and then we got the fruit showing up over here, okay? So one of the things that you're going to find is that in modern medicine, in natural healthcare, right? By the way, natural healthcare has completely gone in the opposite direction, from what I feel like they should. And for the most part, natural healthcare is trying to be allopathic medicine, but with less intense interventions. And it doesn't work. It's like it's working on a fire, right? So you got to be mechanism based, which is what integrated health is all about. And if you look at this, you can see the mechanism here, and the patients can understand this. So they show up with obesity issues. They want to lose weight, or take the pressure off their knees, whatever it might be. They have joint destruction. Maybe they got diabetes, high cholesterol, high blood pressure along the way. But the point is that these are fruits of an underlying issue. And for patients to miss the underlying issue really doesn't serve them appropriately, right? And you guys know that, but what you're getting is this prolonged Th1 activity starts to recruit inflammation that drives the obesity mechanism. I just did a webinar the other day on how neurologic inflammation drives obesity apart from exercise and diet. It's amazing. Okay, so here we have this prolonged inflammation that might turn into autoimmunity and get joint destruction. Maybe you got autoimmunity associated with diabetes or otherwise. But seeing this, right, you can have straight Th1 activity that drives patient in all of these directions. What we want to do is we want to figure out how to lay an axe to the root of this mechanism rather than just continually medicating with nutritional products the problems here. Like, here's your stimulant for your weight loss issues. Here we have, straight chondroitin. Don't do anything with your diet, but here's chondroitin sulfate for your joint issues. And then, your cinnamon pills and all the stuff for diabetes. And it's like the body's more complicated than, trying to douse the candles when they get lit. We got to figure out how to lay an axe to the root of the mechanism here. And so that's what I want to show you in the medical literature as it relates to this human cell and tissue product intervention today, okay? So just for what it's worth, I'll send you these slides if you want, Dr. Clearfield, but basically, if you can show patients in a root and fruit mechanism like this, what's going on, what you're working on, it's like, it's a no-brainer for them. And when you make it a no-brainer for the patients, the intervention is completely understandable, right? They will tell you what needs to be done before you can even get it out of your mouth, right? And it's amazing. So anyway, here's your gentleman once again with all of the fires. His whole body is on fire, right? He's got standard American lifestyle driving the inflammatory situation. So remember, Th1 activity is supposed to be localized for local tissue inflammation, like the sprained ankle. But this gentleman's, if you look at him, you can tell his physiology is not real happy right now. And part of that is because the localized inflammatory issue has gone systemic, and this systemic issue is going to require you finding the right axe, right, to lay it to the roots of the tree. So just so we can get that. Right. So looking at this, I just wanted to highlight a couple of things that these researchers had to show us in 2009, because it seems like such a long time ago that people started talking about the promise, the promise of stem cells, and this situation that showed up, the promise of stem cells. I mean, where has it gone? Right? We get all of the regulation and stuff that's showing up now, and companies can sell product, and then they can't sell product, and now they can, and they're back online, and then they're turned off again, and we get this situation that shows up. But what I wanted you to see from 2009 is that these guys had a pretty bright outlook on what was going to happen with stem cell therapy, and it's because they were looking at pluripotent stem cells, and we're not doing a lot with those right now as it relates to clinical intervention, but we're seeing a lot of that in the studies. Okay, so when we look at pluripotent stem cells, obviously they can become anything in the adult body, and multipotent are the ones that we're looking at as being used clinically right now, because obviously you don't want to fund cancer and crazy stuff. So when we look at this, the cell sources, characteristics, differentiation, and therapeutic applications that they discuss are pretty interesting, because they show you in this review here, they show you what we can do from an epigenetic perspective to turn them off and on. Well, if we can turn stem cells, human cell, and tissue product off, we probably want to know about that before we go around putting $3,000 of tissue into somebody's joint, and then they turn it off with their lifestyle. Because there's two types of inflammation in the body that we discussed so far, and one of them is helpful and one of them is not helpful. And so we're going to expose that here as we go. Okay. So anyway, when we look at this from a multipotent stem cell, you see here the differentiation into these multipotent ones. This is what FDA has essentially allowed people to work with, and you get the bone, muscle, blood version. But this is what the FDA has allowed people to work with. Okay, this is really where the magic is going to be once they figure out how to make sure that people's epigenetic soup that we're putting these into don't funnel them in the wrong direction. And I'm kind of excited about it. So the next 10 years are going to be like golden era for this kind of stuff, and you guys are really, you have an opportunity to be at the forefront of it. So I think that's kind of cool. But anyway, when we look at multipotent stem cells, we want to really think about the term that I mentioned, the epigenetic soup that we're introducing these into. We want to think about these in terms of like a seed being planted into the soil. The soil is why we can't use pluripotent stem cells clinically the way that most people would want to, right? Because the soil is what's determining what these things become. It's so interesting. So I was in a lab, I won't say which company, but I was in a lab, and they make human cell and tissue product interventions for clinicians all over the world. And I was in a lab talking with the docs and the lab director, and I said, what is the biggest problem right now that you see in this industry? And he chuckled a little bit and he said, gut health. And I had to laugh a little bit as well, because gut health is curious. There's a homing mechanism that I'm going to show you here with stem cells. That homing mechanism, you put stem cells into somebody's joint tissue, right? If their gut's on fire, those stem cells, they're packing up, right? Where are they going? They're going to the source of the largest, site of inflammation, if we can put it that way, right? And they're intelligent, and they follow the signaling pathways that are in your patient's bodies. And so we have this mechanism with leaky gut and all of the different things that are going on, especially when you look at the gentleman that we're talking about here. where we have lipopolysaccharides entering into the bloodstream, lighting NF-kappa beta on fire, and that's going total body, and it's all sourced in the gut. Okay, and so we see this play itself out over and over, and we got to ask, how come that patient's own stem cells that he's making in his bone marrow, that he's making, how come those stem cells aren't doing the job? How come he's got to come to you where you're going to introduce, a new product, a new version of it to his body? What was the difference between him being able to participate in it on his own and now he needs you? Okay. So a couple of things, I'm not going to read all of these obviously, but I just want to highlight some of these things. Endogenous stem cells right now are a necessity for a lot of people that are struggling because the cell trafficking mechanism for their own stem cells has been turned off, right? As you're going to see here, reactive oxygen species and the suppression of substance P will turn off your own stem cells' ability to locate sites of inflammation and participate in tissue regeneration, right? So that's essentially what's happening. They need you because they've turned off their body's ability to signal stem cells to traffic in the right direction. It's pretty interesting, okay? So in the aging process, inefficiency in the endogenous stem cell mediated healing mechanism emerges from a variety of impairments that accumulate, right? I think that's the key term right there, is accumulate, in the process of stem cell self-renewal, function, and differentiation, okay? Pretty interesting. The intrinsic pathways that are present here are being told for a lifetime to shut up, go away, be quiet, okay? And your body listens pretty well after a while. So these guys here in this 2017 article talked a lot about reactive oxygen species and nitric oxide, and really what happens with the body's ability for those homing mechanisms. Okay, so imagine you are that patient that I had on the screen here. Imagine you're that guy, and you show up, to the doctor's office because you got a bum knee, and you think it's an old football injury. Okay, when it might have been an onset from an old football injury, but really what's driving it now is the constant Miller Lite, right? Or the patient having, too much Pizza Hut on a daily basis. Okay, why? Well, because it's right next to the office, right? And so anyway, the old football injury becomes a chronic situation, and now we have this degeneration taking place because reactive oxygen species buildup and breakdown in the nitric oxide pathway is driving NF-kappa beta activation in these mTOR pathways, and we get these tissues just disintegrating, right? Like wet paper, just disintegrating. And ultimately, these patients have to be introduced either to large amounts of antioxidant therapy, or these patients have to be introduced to human cell and tissue product interventions, right? And hopefully they stay localized. Now, everybody knows that, when you're taking anti-inflammatories, et cetera, you can't participate with human cell and tissue interventions effectively because you turn off the inflammation that's inherent in the intervention. The cytokine response in that injection is going to be turned off by those medications, anti-inflammatories in general. We'll just classify that in general, okay? Now, antioxidants, right, have the capacity to do the same thing, but remember, antioxidant therapy as a means of anti-inflammation has the ability to be trafficked, if I can say it that way, and has the ability to participate with human cell and tissue product intervention, as opposed to downregulating the cytokine response. Super interesting. So if we have, I don't have the slide here today, but if we have an inflammatory response and a cascade, and we see the entrance to the cascade, and then like 60 mechanisms wide on the bottom down here, if we go with an anti-inflammatory medication, that's pretty high up the cascade and it shuts everything off, okay? But if we're using products, like glutathione or N-acetylcysteine and vitamin C and arlopoic acid, et cetera, if we're using products like this, right, those are so far down the cascade that they are considered selective right? Get that, selective. That's pretty interesting. So that means that you can get your patient's benefit, right, in controlling reactive oxygen species and tissue breakdown while also pairing it with human cell and tissue product intervention that gives them the capacity to start some tissue regeneration without turning it off. Okay. Now let's take that a step further, because if we can put, here, if we look at this mitochondria and we see all of this reactive oxygen species buildup, that's metabolic dust. Okay. Like, how long are you willing to live in your house before you dust it? Right? How long are you willing to do that? Well, the same question you got to ask patients, and it's something that I ask patients quite often. How long are you willing, right, to live with a body that is producing large amounts of metabolic dust like this without cleaning it up? You got to put some dust busters in there and get busy, right? What are the dust busters? Antioxidants, right? Something that's going to get in there and vacuum up all of this metabolic dust, right? And think about this: even if you decrease their overall, ROS load by 7%, 12%, that's pretty amazing when we're talking about the body's innate capacity to heal, right? And giving it a little bit of room to breathe and, really start healing the edges of the cut together, so to speak, even though this is a metabolic cut, right? So just interesting. So when we look at the variety of epigenetic modifications talks about here in chromosome architectures, what they're looking at is a gradual increase in inflammatory burden over time, driving down, right, the tissue repair and anti-aging effects of substance P. Substance P is that homing mechanism that causes the stem cells to traffic toward the sites, right, of intervention or where they're required. The problem is, like, get this, you got knee pain required because maybe we're bone on bone at this point and the tissue's not regenerating the way it's supposed to, or in an ideal world would. Those stem cells are made like 4 inches away, right? They're made like 4 inches away, and they cannot find that site of inflammation effectively because we lose our ability to participate with this little bugger, substance P. Okay, so when we see this, we got to ask the question of what turns off substance P activity, because if you could turn it back on, you probably want to participate in that, at least in a similar mechanism, right? And just really interesting. So if you guys have never read this study, just grab it on PubMed and just take a peek. Really interesting findings that they have here. Okay. Wanted to highlight this substance P. What causes substance P to take a nosedive in its functionality, right? Well, modifications to DNA and non-coding RNA mediated mechanisms, as they say, are epigenetic events that play important roles in regulation of the progenitor cell function by changing chromatin structure. Okay, so we start seeing changes to our DNA expression, right? Because we start changing chromatin structure and substance P starts backing away from the party, so to speak, right? The epigenetic changes in adult stem cells are critical during aging because they alter the function, clonal composition, and lineage of stem cells. They alter the lineage of the stem cell, right? That's the key line right there. They alter the lineage of the stem cell. Okay, so if we have epigenetic situation that's not allowing our patients, to heal, like this gentleman I told you, he's got a sit-down job. His sit-down job is ultimately leading him to a life of like luxury, right? So you see, sitting down is a luxury on the job, right? Our body is definitely not. It's not set up for the sit-down lifestyle. Okay, when we start looking for like comfort, the body starts to fall apart, and that's just an interesting thing. But this is why we start seeing the DNA changes here. The epigenetic switch is just changing the expression. The lineage fate of stem cells is what we want to talk about. It's regulated by intrinsic and extrinsic epigenetic modifiers, as you see. And what I find in this is that if you give somebody a shot at adjusting their lifestyle for tissue regeneration, not a lot of people say no to that. The problem is that we have to then quantify what lifestyle intervention is required. What does that even look like? Okay, what does that even look like? So hang on here for a second, all right? So I'm just going to plant that flag there, and we got to ask that question. We got this guy. He's got tissue regeneration issues. He wants human cell and tissue product intervention. He wants to do some lifestyle aspects with it, or I'm going to recommend it at least. What does that even look like? Okay. Substance P here, right, is expressed in a variety of non-neuronal cells: chondrocytes, osteocytes, osteoblasts, osteoclasts, and mast cells, right? Now, I wanted to throw that out there because if substance P receptors are present on these tissues, that we're asking these tissues to like wake up and do something, right? We got to figure out, how do we get substance P activity to rejoin the party, right? It's neuroimmune modulation is the name of the game. So I mentioned a presentation that I had recently given about obesity being driven by neurologic inflammation starting in the central nervous system, and how that can't be turned off by exercise, which is why the exercise industry nets 7 to 10 pounds weight loss on average for anybody when people need 25 to 30. Okay. So looking at this, substance P is also participating in the same neuroimmune modulation mechanism. And, when that inflammatory situation is present, these people are just falling apart because substance P is taken off the playing field. Okay. So taken off the playing field. Now, pain is supposed to be a modulator or a signal that says, hey, substance P, let's show up here, right? Experience some pain so that stem cells know where to go, right? I remember an injury back when I was a kid snowboarding, and my knee swelled up like the size of a melon. It was huge. It was huge, right? And that huge inflammatory situation was my brain signaling through the immense amount of pain, signaling, hey, stem cells, this is where we need to participate. But if you look at substance P and blocking pain signals, and what we do basically from a medical perspective at this point in time, people are living pain-free lifestyles through chemistry, right? That decreases some of the activity of substance pain, and I don't want to discount that, right? Or substance P, I should say. So anyway, so here we are back at our tree, our root and fruit mechanism. Gentleman's got some tissue issues going on, okay? Does he have food allergies? I'm going to look, right? Does he got mold issues? I'm going to look, right? Lipopolysaccharides, almost everybody's got lipopolysaccharide issues, okay? And what's it look like as far as alcohol and his ethanol intake and what that's doing to his gut? So from a diagnostic perspective, I don't work for these guys. I'm not affiliated with them, but I really appreciate the diagnostic workups that you can get from a company like Vibrant Wellness, okay, where you can look at total tox panels that look at biotoxins, molds, issues, et cetera, like that, along with, maybe heavy metals and environmental toxins. Those are the biggest ones that I see right now, especially in my area of the country. You look at organophosphates being used, spread on the field, essentially to produce crops. And these things are driving mass degeneration, both neurologically and musculoskeletal degeneration in an entire generation of people right now. And it's a massive transfer of wealth that's taking place, by the way, between the baby boomer generation and everybody that's willing to sit there and serve them. Okay. And I don't think it needs to be that way. If you can look at tox panels and actually do an actual workup on patients in a way that is meaningful for their lifestyle, how to generate a lifestyle, well, if there's something in your body that's not supposed to be there, we should probably get rid of it, right? And so if we can look at tox panels, or they have Zoomer profiles, which are amazing as well for IgG, IgA, even IgE, and looking at food issues, the diagnostic scenario that's available to us in 2022 is just remarkable, right? If a patient's willing to participate. And that's where a slide like this comes into play, is showing them, right? If you're going to lay an axe to the root of this tree, your lifestyle plus your genetics is creating this tree, the obesity, joint destruction, and the diabetes issues. So what does that mean? What are you going to change in this equation, lifestyle plus genetics? You can change your lifestyle, right? And ultimately, in order to figure out how to create a lifestyle that people can participate with, that gives them the ability to have proper health and healing, you got to have the diagnostics to do it. And so, in my opinion, the biggest hole in integrative therapy is running tox panels on patients. Okay, it's the biggest hole. By the way, I'll just say this. When a patient sees that there's something in their body that's not supposed to be there, right, they know what the treatment plan is and they can't say no, right? If I show you that you have organophosphates in your body and those are diabetogenic, okay, they're diabetogens. The FDA knows they're diabetogens. It's from their own research. And you go home at night and you're like, yeah, I think I'll just risk it, right? You're not going to do that. I think I'll just risk it. No, you're going to figure out a way to support your body's ability to process / remove / avoid these diabetogenic compounds. Well, the same thing when we look at things that target tissue destruction, okay? We're going to avoid those. All right. So anyway, I'll get off that horse there for a second. Here is the situation. Substance P will make a comeback, but most of the time it will only happen in autophagy. Okay, here's the problem. If we look at human cell and tissue product interventions and you're like, all right, we got to do a lifestyle here. How many of your patients are going to be willing to fast, number one, and for the appropriate amount of time that's required, right? So guesses on fasting, like if we're all live here in a classroom, I would ask you. Most of the time people ask about this and they say, I don't know, 3 days of fasting. Nope, not for Substance P to make a comeback. Okay, not 3 days, 7 days. How many of your patients are not going to eat for 7 days? The answer is none. Okay, like I like to do stuff like that, but it's more of like an exploratory process and figure out what are the boundaries. Okay, and for me, I will tell you that after 3 days, I gotta draw the line. Gotta draw the line, and I find that for most patients, they're not willing to go more than 24 hours. And so this like fleeting autophagy is really where we're at. Okay. So anyway, autophagy here is has been viewed as a non-selective housekeeping process, but really what you want to think about is our viewpoint on it is evolving, and increasing evidence demonstrates that autophagy is an active program. See, that's interesting because a program means that it's set, right? It'll deploy itself when a demand is put on it. Okay. And the problem is, the United States, we don't ever put a demand on that program because, well, life's pretty good. We have a lot of options. So what it requires, autophagy, is lack of comfort, right? So if we remember, I said that, immunologists gave us that Th1, Th2 teeter-totter understanding. And maybe if we have a new teeter-totter in integrated, therapeutics, we could think of that as like comfort versus, discipline, like this balance here, comfort and discipline. Because ultimately, if we have an opportunity to put our patients into autophagy, they're going to get better. Now, one of the things that we see with autophagy is that you have cell membranes that begin to have pretty awesome renewal process, mitochondrial renewal. You look at the envelopes that they're in, and then we also look at actual cell structures, cellular structures, having the ability to participate in that homing mechanism once again with Substance P. Now, there are other ways that we can support cell structures, right, without having our patients, requiring them to not eat for 7 days at a time. And, and then they fall off the wagon and Old Country Buffet is back in, and, and the tissue destruction remains. So it's interesting because if we want to not turn off the human cell and tissue product that's introduced to their physiology, we have to figure out how to get them participating with cell membrane therapy once again. Okay. So, and ultimately that's what we're talking about here. So here's just a 1-slide review of what we've talked about thus far. Okay. You got 2 patients, 1 result. If we can work on the lifestyle of the patient that has the lifestyle that's not compatible with health and healing. Okay. So lifestyle plus genetics equals chronic inflammation. We get that ROS buildup. And this is not even in patients that have like autoimmunity or food issues. This is just in the general population, right? And chronic general inflammation specializes by Th17 activity into tissue destroyers. Right? Their own stem cells are less viable because Substance P is no longer acting as a homing beacon for the trafficking mechanism. ROS degrades that stem cell potential, Okay? And so we leave all of that potential locked up in the tissue. Patient shows up to your practice, autophagy is one option. Are they going to participate in autophagy? Sometimes they will, but for how long? Right? We use plug and play cell membrane enhancement, right? So support mechanisms that we use with that, phosphatidylcholine, large doses of antioxidant therapy as it relates to vitamin C and our lipoic acid. Basically just giving the body building blocks to lay down new scaffolding structures so that when we start putting new tissue down, we start putting that layer by layer, they have the ability to participate in it, right? Now, the kit that I'm talking about here was the first kit on the biogenetics slide that I showed you at the beginning. But what we want to think about is ultimately I'll talk about that in a second. But what we want to think about is ultimately we want to be able to support the patient's ability to get through that initial inflammatory mechanism from the human cell and tissue product intervention without turning it off. Okay, that's the point of pairing nutrition. So you have three options. Okay, you have no nutrition and introduce the cells, see how they do, and it's good. You get pretty good results, right? Like let's be real. We have the other one where we could go through a root and fruit mechanism where we could do an actual lifestyle reset with something like our metabolic clearing program and teach the patient how to make better choices. And we actually get, to the root ROS issues. And then we have the third option, which is a plug and play. And, patient doesn't really want to change their lifestyle. That's all right. Right? We have this third option, which is the Regen Kit, as we call it here. Right now, I want to talk about these guys because these are liposomals and they're put together in a way that allows for maximum absorption. And they're very tiny, and the liposomes are so small that you can see through the liquids. And what's interesting about that is that when liposomes are too big, you get cloudy tinctures, and that defeats the whole purpose of the liposome. So we want to make sure that we're able to bypass some of the gut issues that these patients are having so that we can get the phosphatidylcholine into the bloodstream relatively swiftly. Same deal with the vitamin C. Now, vitamin C in integrated practice, you guys probably talked a lot about vitamin C over the last 2 years. But when we look at vitamin C, there's a shutoff mechanism in the gut. And typically, you're going to get a flushing reaction associated with 1,000 to 1,500 milligrams, somewhere in there. And you won't get that with a liposome because a lot of it is going to be absorbed in the mouth, right, through the tissue layers in the mouth, and then also the esophagus. So pretty interesting. The other aspect to this, why we use these, is because we're trying to control lipopolysaccharides that are lighting NF-kappa beta on fire and creating most, I say most, bold statement, most of the inflammatory issues that patients are dealing with systemically from their lifestyle, right? So it's a pretty interesting scenario. But if we can get phosphatidylcholine to start working its way, down the esophagus and the stomach into the duodenum, and start changing the output of these lipopolysaccharides that are being created by gram-negative bacteria in the gut, and you get a pretty good response. It's pretty fun. So this has been consistently one of our best and most utilized products in the space just over the last couple of years since we built this, and it's been pretty fun. So I like the patient stories. So if anybody does use this with their patients, make sure you send us your stories. I like hearing those things, and it helps us make sure that we get the word out as well. So anyway, what I want to do is just briefly here give you Kim at Biogenetics, right? This is part of the crew here. So they probably don't know that I put this picture up there for you, but they sent it to me, so that's what we get today. But anyway, Miss Kim is somebody that you can reach out to if you want access to any of this information. If you want access to any of our learning library, we have, oh Lord, probably 300 hours of integrated education on nutrition. And it's all classified and organized by conditions and interventions, which is kind of fun. So you can check that out. It's all free, by the way. All I got to do is email Kim, and she'll get you plugged in and organized that way as well. So one of the things that I'd like to do at this point, Dr. Clearfield, if you'd like, is I got a couple of minutes left, it looks like. If you guys, anybody has any questions, or you want to talk about something as it relates to stem cells or nutrition, anything like that, I'd be willing to do that.
We have a couple of comments and questions. One, Dr. Southard asks, do you use the Alcott test?
Sometimes I will use the Alcott test, and they do a good job at creating accessibility for patients. But one of the things that I like is the report structure that I can get from a company like Vibrant Wellness, or Cyrex is a competitor of theirs that does a good job as well. And those reports are based off of a unique set of data, right? So Alcat is based off of their own data, and these other reports, I find a more targeted and organized report for patient consumption. So I'll say that. So, but I have used Alcat. Yes, I have.
More of a comment from Dr. Ortel. She states that you have to work up to a 7-day fast as patients are mostly insulin resistant. What do you think about adding ketones to get over the flu-like hump?
Yeah, so that's a good question. There are ketone products in the marketplace that do work well with that. If you're going to do fasting with diabetic patient, obviously there's a whole bunch of issues associated with that. But you know, ketones are certainly a way to circumvent some of the mess that shows up. So I like that. And they have some pretty good technology with flavor profiles for those too. So they're good.
Then she states, then proceed to start with 2 meals a day, then 1 meal a day, 2 days a week, and it should get easier. And she states
that's
her
right.
husband doing that, they're in their late 60s and not likely to go over 7 days.
Right. That's good. Very good.
So that, how about cytokine testing? Do you do any of that?
I do cytokine testing.
And since we're allowed to talk about it, do you have any companies that you're
Yeah. So for cytokines, I will use either Vibrant Wellness, once again, or Cyrex.
Okay. Any other?
Yo, go ahead.
Okay. Can you give us kind of a breakdown? So somebody comes in and you have your detox suspicion.
Yeah.
Where do we begin? You know, some of us are old timers and we're regular doctors, and we're just coming to this late. So
here. So let me get this slide up here for you. This will give us something to talk about. As we look at the root and fruit mechanism, the idea that we can help a patient reverse the symptoms of their chronic condition and walk away from chronic disease is, you know, new. And I say new, like 1970. And this idea of, well, how do we do that? We got to find out what the inflicting agents are, right? So the testing is where we always start. So for myself, I'll never take on a patient case unless I have data that backs up, hey, this is what needs to happen. So patient shows up, Dr. Clearfield, you show up at the practice, right? And you say like, hey doc, can you help me? I have diabetes and brain fog and my joints are driving me crazy or whatever. Can you help me? Well, I have no idea if I can help you. I have some suspicions, okay, but I have no idea really. It's going to require me to have some valid data in order to be able to put a treatment plan together for you, because it might be 3 weeks, it might be a year. It just depends on what we find. And so I find a lot of value in doing tox testing plus blood chemistry. So I use blood chemistry tests through Avexia. If you guys want, I built them for biogenetics through Avexia. They're preloaded into Avexia accounts. All I got to do is ask the rep to load your account with it. And it's our basic blood chemistry panel that we're able to get great rates on instead of having to bill insurance like $2,000. So we can get the testing for, you know, around $200. Some of them are way less than that even. But the point is that it makes it accessible for patients so that I can actually get a picture of their health. The blood chem gives me a snapshot as to where are you right now, right? And then the tox panel tells me why, for the most part, if I'm looking at chronic disease. If you're looking at kids or, like pregnancy issues, stuff like that, then you start looking at less tox panel induced issues. And you start looking at hormones and, that type of thing. I would anyway. So, those are the two basic that I'll use, tox panels and blood chemistry. Now, there are ancillary tests that you can run if the case calls for it. And sometimes I'll do Dutch testing, which is hormone profiles based off of metabolites, not just free fraction hormones. Sometimes I'll do organic acid testing, which is an old favorite of integrated practice. Just depends on what the patient case calls for. So all of that data, right, whatever is required without breaking the patient's piggy bank, all of that data being able to give us a synopsis essentially that says, here's what's going on, here's why, and then we have to figure out what to do about it. Okay, so I looked at a case this morning, where the patient has 95th percentile cobalt in their bloodstream. How did that get there? Right? And secondly, some of the psychological symptoms associated with cobalt toxicity are destroying this person. Okay? And nobody looked. And so they asked, usually by the time they get to somebody that practices in the functional space or the integrated space like this, they've already gone to everybody else. Okay. So they had a good battery of tests and stuff, but we looked, found it. And so now what are we going to do? We got to figure out where the exposure is coming from, mitigate it, and then support patients' ability to process phase 1, 2, and 3 liver detoxification, and maybe harness a little of the integument as well. And, it'll probably take them 3 or 4 months.
Does the patient have any artificial joints?
This patient did not. Yeah.
Because there was a time when they were using cobalt, was leaching out of hip replacements.
That is interesting. Thank you for saying that. That is interesting.
Well, that's, I ran into that when I was in Northeast Pennsylvania. We had a whole rash of cobalt. It got to be a joke because we didn't know where it was coming from, and
Yeah.
it was actually from joint replacements.
Wow.
We have Dr. Foley is when he asked a question. He's an orthopedic surgeon. He has some insight into that.
Yeah.
But that's the first thing that comes to mind when you say cobalt. I think artificial joints. So
that's pretty
search around, see if they have that.
That's pretty great. So thank you. So seeing this.
In fact, he writes metal on metal hips causes this. So
wow.
He wrote that. So
thank you, doctor. So seeing this, right, gives you start to formulate a plan now, and that plan you can communicate to your patient. So what are we going to do? Let's say this patient, like in this little blue box that I have here, this was just an example. Patients got food sensitivities or IgE mediated allergies, biotoxin issues with molds. That's a huge thing right now, especially below Illinois, I'll just say, with the mold exposures. Lipopolysaccharides, that's almost everybody. And then blood sugar is a huge key for most of these cases as well. So rectifying those issues that you find in a patient laboratory report, and and if you're not familiar with how to do that, Biogenetics has a feature. It's a free service, which is pretty great, but it's a clinical consulting team. You get patient laboratory data and you're like, well, now what do I do? We'll show you how to do it, right? Even if it requires products that Biogenetics doesn't manufacture, we'll tell you what to get and where. And it's a free service. So, and all you got to do is talk to Kim if you're interested in that. But last year, I think we did, 3,200 cases, right, through the clinical consulting service, and it's pretty good. So.
Mm-hmm. So Dr. Foley asks, is there an inflammatory component to osteoporosis? And if yes, what would a management course look like?
Question. So I will say in every case I've ever seen, yes. Are there cases where there might not be? I would suppose so. But in any case that I've ever seen, yes. And what we basically want to look at is the connection between thyroid, kidney, and gut and how they're interacting with each other. And so what we will oftentimes do is run assessment measures to figure out, is inflammation suppressing thyroid function, or is inflammation destroying kidney function as it relates to managing calcium content. So that, and we start looking at estrogen and how the body participates with those three as well. So how do you move a patient in the right direction? I'll say it depends on the mechanisms that we find in their laboratory chemistry.
Okay. Kind of answered this already, but maybe one more time. Dr. Crowley asks about can we get lab information that you use? So I guess the lab, if you go through which labs are your favorites that you found?
So I use the Biogenetics General Screen for blood chemistry, and that one is at Avexia. Avexia is just a buying group, so you can, purchasing power with 1,000 other doctors, and that way you don't have to pay crazy prices at LabCorp, right? So your patients can get great labs for, it's at LabCorp, but you don't have to pay exorbitant fees, and it's pretty awesome. They have a great service. So I'll use the basic biogenetics general screen there. And you look at all the major organ systems, look at the inflammatory pathways, the patterns, what do we got going on there, snapshot in time. And then I will usually run tox panels. There's a panel called a total tox panel from Vibrant Wellness that will measure metals, mycotoxins, and environmental toxins. And the stuff that we find it's almost unbelievable unless you're looking at it. We see a lot of diabetes cases. It's just really low hanging fruit in the society we live in today, but also a lot of people that are getting destroyed by it, and they need somebody to serve them. Well, if you're doing that, there is, part of the tox panels looking at organic, pesticides, etc. And these are diabetogens, as I mentioned, earlier. These diabetogens, it's a term that not a lot of people are participating with yet, but it's been in the medical research and the literature for over 20 years. Diabetogenic or diabetogens and organophosphates, farming chemicals are right at the top of the list. So if I look at 100 cases in the next month, I guarantee you 85 of them will have chemical toxicity associated with the diabetogenic effect. So it is pretty wild, like stuff I wish I would have knew 10 years ago. But thankfully, Vibrant Wellness is able to put it out there at this point as well. So that's pretty good. So I'll look at that. Then if I'm looking at hormones, I'll do blood and something called a Dutch test. And a Dutch test is at dutchtest.com. And they do a great job of looking at metabolites. And you can compare that with your free fraction in blood, et cetera, and you get a pretty good idea of what's going on.
Okay, thank you so much. A couple of months ago, I actually presented a case. It was a 34-year-old woman who had all sorts of brain fog. Everything that you've been talking about had been present. No, she was 39. It's been present for 4 or 5 years. I did what I do, and we sent her for a micronutrient test. And I used Genova, and they combined their micronutrient test with heavy metal testing, and I accidentally checked it off. I didn't even realize it was the first time I had used the new form, and it turned out that she had gadolinium, off the charts. So I went and asked her. She'd had 3 IV contrast MRIs about 3 to 6 months before all the symptoms started. So it was fairly sensitive. So she went to Stanford. They ran their own, which showed nothing, and said, well, she didn't have it, and we didn't know what we were talking about. But they were doing micrograms, and I think Genova measures it, if I got it right, is in picograms, so much more sensitive. And I presented a case here to the group. It was pretty interesting. But then getting rid of it is a whole nother story.
That's right.
So any experience with that at all?
Yeah. 2 weeks ago, I had a case of the same thing. It was a kid that's got a genetic issue. He's 21 years old, and he's got diabetes and his kidneys are getting destroyed, right? And so we look at some tox panels with him, and one of those things, can you help me? No idea, but let's find out. And he loaded with the same thing because the doctors have been giving him contrast studies 2 a month, trying to make sure his kidneys don't die. And pretty interesting
That's kind
scenario.
of what kills them in the first place, isn't it? The contrast.
So and it's not my place. I'm just the nutrition guy, so it's not my place to say what to do with that or not. But I tell him, hey, if it were me, I probably would consider not taking pictures of him so often, right? But anyway, when we look at that, we want to think about the removal mechanism, especially in somebody that's got sensitive kidney tissue already, because the kidneys don't usually come back very strong. Right? You can rehabilitate them sometimes, especially in a 21-year-old, but they're sensitive little buggers, right? So it's not like you want to, put all of that metal into the bloodstream and roll the dice and see what happens. So we'll use glutathione, obviously. I use liposomal glutathione, part of the process, the detoxification process that I put together for biogenetics. And the liposomal glutathione is pretty awesome. The studies on this stuff are amazing. Over IV therapy, you get 100x cellular uptake. That's kind of crazy. Okay. But anyway, when you look at the process, you want to think about, how do we do the most for this kid without having a deleterious effect? And glutathione and binders. The binders for me are a game changer. Small intestinal reabsorb up to 90% of metals that you detox. That's like if you mowed your lawn one day, that'd be like you having to go mow 90% of it the next day again, right? Like you would never stand for that, right? But in detoxification, you reabsorb 90% of what you spent all day detoxing. That is why we end up with massive kidney issues in people with heavy metals. So it's just constantly making the kidneys try to filter, or expose them to these chemicals over and over. Right. So efficiency in detoxification is what you want to figure out. So those two are key. And the detoxification protocol that we put together for him was based off of something that we call the metabolic clearing kit at Biogenetics. There's a deluxe kit which comes with a bunch of liposomal antioxidants that we use specifically for this type of issue. And the other thing that I had the kid do is get sauna at home. Right. And, do his best to sit in the sauna 35 to 40 minutes a day, 155 degrees, and just see if we can start pushing, if not some of the metal, the contrast dye that was in there, the other issues that his body is dealing with, the other toxicity issues, so that we have some energy to spend on detoxing the metal. So that's pretty cool. So we're going to run another test on this kid coming up, probably in 60 days and see what we're looking at.
Okay. Well, thank you. This was terrific, and please come back anytime.
Thank you for having me. I appreciate you.
Thank you. It sounds like that your team is more than just you and one or two people in the background there. How big an outfit?
So Biogenetics is, oh man, we're less than 20 as far as the office staff and all that kind of stuff. I don't know how many employees they have, but I consult to Biogenetics. I don't own Biogenetics. I just consult to them.
Okay.
And so they're a good team though. And I appreciate their customer service, which is one of the reasons why I agreed to work with them. So they're pretty great.
Next question. Someone who does presentations quite often, it takes me a long time to get my materials together and all. How do you do it? I mean, how do you every week you have something new?
Yeah.
Okay, this month we're going to do 4 hours on menopause. Next month we're going to do 4 hours on the genetics of gut health. I mean, how do you do it?
So number one, I'm just curious, right? There's a lot of stuff I don't know, and so you find something you don't know and you go down that rabbit hole, and that curiosity is interesting. The other thing is I always want to find out, what does it mean? right? There's tons of providers that know a lot of information and a lot of researchers that are, you know, terrible at putting presentations together because they don't know how to major in the majors and minor in the minors, right? So if you want to figure out your niche is this, okay? This is it. Nobody's ever asked me this before, so I'm going to give you the secret. The secret is this. Most researchers have no idea how to talk to another human being, and so I read their research and I put it into terms that people can understand, so it means something. That's all.
There you go. That's great.
That's it. Yeah.
That's great. So I can't thank you enough. And Kim has been great. You know, we were supposed to do this a couple of months ago, and something happened. I don't know if you had a family issue or something happened.
Yeah, there was a
But
death in the families.
but please, you know, please, um, if you don't mind, we would love to have you on, at least on our mailing list to keep up with
Yeah,
us.
that's great.
And please come back. I mean, you are a unbelievable font of knowledge, and you know, a lot of our group are. We started out as hardcore medical doctors and then saw the light. So some of us come to it a little bit late. You can tell by my
Yeah.
hair that it's, you know, this is silver, not gray. But we've gone over to the dark side, and I can't thank you enough. And if you look at the chat, you'll see great talk, you know, up and down the line from our speakers. One question: does Chinese parsley slow the reabsorption of detox materials?
It can, yes. So that's right. It can. I like to use usually clay and aloe based binders. And so the clay and aloe based stuff are it's pretty good. It's pretty good. So there's a gentleman by the name of Dr. Chris Shade, if you're familiar with him. And he's the gentleman that we had customize our binder product. He's you ever want an interesting guest? He's a riot. All right.
I will be on the text message with Kim later to get his contact.
Yeah, if she doesn't have it, just tell her to ask me and I'll get you guys connected, okay? So he's the world's foremost authority, in my opinion, on heavy metal detoxification, and he is an entertaining individual. So
Wow. And one further comment, and don't take this the wrong way, but I rather like the Steve Jobs, Elizabeth Holmes look.
well, I will tell you
gives you you know, that kind of humbled look, but
Yeah.
genius look. So
well, I'm in Minnesota today, and it temperature was just plummeting.
yes,
So
say no more.
So thank you for having me. I appreciate you guys.
Thank you so much. Anybody else have any other comments, questions? Again, if you look in the chat, we have a new website for our conference. And we will be sending out information. We're about 2 months out, and we will be getting AMA CME credits and AOA CME credits. And so, you know, no excuses for the MDs in the crowd. Like I said, we have a superstar lineup. And if anybody who knows anything about anti-aging medicine knows some of these names. You would pay $2,500 for 3 days at the A4M to see these folks. Some of them get $5,000 for an hour's talk, and we have them all. So it's a little bit more expensive than we're used to. But we're in Las Vegas. We're right on the Strip. We have some, as you know, those of you who've been with us before know that we have some pretty nice entertainment. You know, we've done Sinatra type cocktail parties. We've done murder mystery dinners. You may want to come, Dr. Watts.
Hey, I'll be in for that. That's fun.
Okay. We have a good time. We have some interesting vendors coming. We actually have some compounding pharmacies will be with us this time. And I really want, you know, to get a nice crowd. It will be online. It will be virtual. Somebody asked if it's going to be on Zoom. Probably not. We have a private company we're working with. Anything else, Dr. Watts? Again, it was terrific. I know I've been bugging Kim to get you on, and so we're really glad that you were able to be with us. We are here every Tuesday night at this time, by the way.
All right.
So
Well,
you know, if
make
nothing
sure
else to
to
do, you can always tune in and
yeah, that's what I was gonna say.
sort of give us your 2 cents on whatever the topic is. In fact, next week we have Dr. Scott Chandler from Provo, Utah. He is a biological dentist, and he's going to talk to us about mercury fillings,
Love it.
infections, and autoimmunity and chronic disease. So as you can tell, we sort of have to hold somewhat fast to our autoimmune roots, which we do.
Yeah.
But much to the chagrin of the AOA, we're pretty much out there. Okay. They have to rein us in a little bit. Wait, one more comment here. Okay, I got a thank you from Dr. Nerio, and great talk from Dr. Crowley. Dr. Kim ALA says Biogenix has 7 employees.
That's
I
actually
was just
Kim.
wondering.
Yeah.
What it sounds like you have quite an operation going. So.
Yeah.
Thank you for the presentation, Dr. Ortel. Thank you for Dr. Albino. Really, Dr. Watts, we can't thank you enough.
Thank you.
And anybody else have any problems, questions? I know it's late back east. So we will be back here same time, same station next week. I said, Dr. Chandler, biological dentist. And please register for the conference and send our flyers and our mailings out to your friends, to your mailing lists. We really want a big showing. And we still have Peter McCullough is supposed to be coming. He's a little hard to nail down. And so it doesn't look like we're going to be able to do CME for him because I can't get him to sign the papers that I need signed. But he's supposed to be there on Saturday. And he's all over the news with whatever it is that he does. I don't have a TV, so I don't watch anything. So again, Dr. Watts, thank you. Kim, I guess that's you there. Thank you so much for everything. Everybody else, any problems, questions? We will have the tape of this up probably within 24 to 48 hours. And Dr. Watts, if you said you would graciously send the slide deck, we'll put that up too. Our website, where it shows up is, for those of you who don't know, aosrd.org/webinars. We have just about everyone. We've been doing this for about 1.5 years, so we have quite a bit of content there, and you can see some of the things that we've done in the past. Okay, everybody, thank you so much. We will see you same time, same station next week. And again, everybody, thank you so much, and stay well. Okay.
All right. Thank you, Doctor.
You're very quiet today, Dr. Burgess. This guy down here, John Burgess, he's my kind of right-hand man here. So he's
enjoyed it. Thank you.
okay. All right. So, okay. Good night, everybody.